Um, Total of 68,096 children were taken in each group. Gender, age at the first diagnosis, and the year in which ADHD was first diagnosed were matched effectively between groups. Level of urbanization was also similar between the two groups. Higher portion of comorbidity, intellectual disability, depressive disorder, autism, and substance use disorder and conduct disorder were noted in patients who were receiving methylphenidate than in patients who were not receiving. Results of univariate repetitive measure time-dependent analysis showed that methylphenidate treatment was associated with significant lower all-cause mortality, natural cause mortality, unnatural cause mortality, and mortality due to accident than in children who were not given methylphenidate. Only one death by suicide in methylphenidate treatment follow-up year was compared with 32 in comparison with follow-up with patients who were not receiving. No homicide death occurred in children who were receiving methylphenidate, compared with 7 who did not receive methylphenidate. Stratified analysis by gender or age showed that reduction in mortality associated with methylphenidate use was only statistically significant in males and those that were diagnosed at a younger age, that is between 4 to 11 years. The mean interval for ADHD first diagnosis to methylphenidate first prescription was around 307 days. Higher all-cause mortality was found in those with a longer time between diagnosis and between the time they started with methylphenidate, and a lower all-cause mortality was found in those with a longer duration of treatment. Coming towards the discussion, the primary finding was that methylphenidate use was associated with significantly lower all-cause mortality. Within the group receiving methylphenidate, a longer interval between diagnosis and first treatment was associated with an increased risk of mortality, whereas longer treatment duration was associated with a lower risk of mortality. Methylphenidate use was associated with decreased hazardous ratio for both natural and unnatural cause for mortality in univariate analysis, and these findings are in agreement with the previous studies. However, after adjusting for the demographic variables and comorbidities, these protective effects remain statistically significant for only for all-cause mortality as an outcome. Adjusted hazard ratio for all-cause mortality was significantly lower in methylphenidate receiving group than in comparison group, and no significant difference was found in natural cause mortality in the adjusted analysis. The age and the gender difference, the study finding indicates that the association of methylphenidate with reduced mortality was more prominent in the younger age group. The result extends previous findings that people with ADHD in childhood and adolescence have a lower risk of mortality than those which are diagnosed in adulthood. It may be due to the association reported that initiating methylphenidate at an earlier age is associated with lower lifetime risk of non-alcohol substance use disorder than later initiation, and substance misuse can result in higher risk of mortality in a general population. Methylphenidate treatment was also associated with significant lower risk of mortality in males, but not in the female participants. This may be due to the difference in the sample size, the event numbers, and the mortality are all lower among the females. This was the first study reporting that a longer interval between the first ADHD diagnosis and the first prescription of methylphenidate is associated with a high risk of all-cause mortality. It may be that receiving a diagnosis and medication earlier may reduce the risk of later adverse consequences. Possible reasons for this may be benefits of methylphenidate treatment in reducing the rates of accidental related cause of death, a low risk of developing substance use disorder, and associated mortality is associated with initiating methylphenidate at an earlier age. The strength of this study is that it is a population-based cohort study which minimizes the likelihood of selection and recall bias, and it is analyzed after adjusting for a wide range of demographic factors and comorbidity. The study was more accurate in identifying association of methylphenidate with mortality. Coming towards the limitation, the diagnosis was taken from a database which was based on a physician's clinical judgment rather than a structural research qualitative interview. Data from the population is only in Taiwan was taken. It is not generalized for other populations. Limited information in the database precluded the measurement of other possible confounders such as the family history, the psychosocial stressor, effect of behavioral therapy, or even the severity of the comorbidities. Although the cohort size was large, the number of deaths was small and had limited statistical power. Because of the relatively low number of deaths and limited follow-up duration, long-term studies with a large sample are warranted to delineate further association between the cause and the intervening causal pathways. Uh, is the association with lower mortality related to the effect of methylphenidate treatment itself, or whether other characteristics of the child receiving methylphenidate accounted for the low risk? Like they have not mentioned any other characteristics of the child, so that can be a confounding factor as well. There is limited information in the database. The control not receiving methylphenidate, were they receiving any treatment? Were they under any pharmacological or any psychological intervention? This brings me an end to my.
Who's the chairperson?
Sir, sure.
Thank you. Interesting study. So in a few lines, you explain them what is the study. Don't go for all those technical things. Just explain them what is the study about.
In Taiwan, there was a database for insurance claim. Whoever patients who are diagnosed with ADHD, they take an insurance claim for the medications they have taken. So this is a study which is comparing the medication that is methylphenidate, which is a stimulant which is used for ADHD treatment, with patients who were diagnosed with ADHD. Now they took children who were diagnosed between 2000 to 2010 and they followed them up till their death or till they migrated or till an end point which was given at 2013. They saw the cause of death, if it was a natural cause, if it was a homicide or suicide, and then they compared both the group, the case and the control. The control being patients who did not receive the medications. And so they compared both of them and saw which had a more number of deaths. So the results showed that patients who did not receive methylphenidate had more all-cause mortality, that is including the natural and the unnatural cause death. And they also showed that patients who were on a longer duration for treatment had decreased risk, hazardous risk, as they mentioned in the article, because maybe if a patient was diagnosed with ADHD before, they had less risk to develop substance use disorder or were less prone for accidents. And they also saw that it was more of diagnosed in males and in children who were of lesser age. Male had more mortality than female, but this can also be because there were a less sample size of death as well, and females. Come. So,
earlier onset, more mortality.
So, no, sir, if there was more time of duration of treatment, then less mortality.
Yes, more time duration between the diagnosis and the treatment.
No, sir, more time means more mortality if longer duration of treatment was taken.
Less.
Yes, sir, longer duration of treatment.
Age of onset?
So, age of onset, they said that at younger age, if they were diagnosed, then it was more protective for risk factors, for hazardous risk for death, for mortality.
Treatment.
Yes, sir.
Treatment also.
So
treatment is more protective.
Yes, sir.
Any other reason we can give? Methylphenidate receiving candidates or methylphenidate not receiving candidates. they found that there is a difference in mortality rates. That is what the study is about.
Yes.
So any other explanations which were any explanation which you feel?
Sir, patient who is anyway seeking treatment will be less accident prone because they do.
So if someone is receiving methamphetamine, the severity will be more.
Yes.
The severity
Of the
shall be
disease.
more. If someone who is not receiving methamphetamine treatments for such a long period of time, the severity shall be less. Severity of the illness, because we
Yes.
only
They
reserve
have not
stimulants for moderate to severe illnesses. Then this comparison becomes a little blurry.
So they have not mentioned any severity before taking. They have just picked up from a journal.
Then how are you supposed to say a group which is probably more severe, high stimulants, has less mortality rates? If you are saying mortality, why they are saying mortality rate is because of illness per se, or complications secondary to the illness?
So not for the illness per se, for the complications, like if they're more accident prone or the more suicide is.
So all
natural
mortality has medical mortality.
Yes, sir.
Like what?
Sir, they have just written natural cause.
Because natural causes is invited when we give, and the methamphetamine rates are associated with arrhythmias.
Yes, sir. That is what they mentioned in the starting of the article, and the presentation. There's a study that it is more associated with serious complications.
But they have not found.
They have not. They have not exactly mentioned any cardiac complication. They have just mentioned the number of deaths. They have not mentioned it specifically. They have just given sir, homicide, suicide, and accident as one, and natural cause as one.
Now, how is it possible if they have followed up data and they didn't develop any comorbidities also?
No, so they have written that they did develop comorbidities, and patients with methylphenidate who were taking treatment were more prone for comorbidities. Yes. So, but they have not given any reason for that. There's just
reason can be illness. And which kind of comorbidities they develop?
Sir, autism, intellectual disability, depressive disorder, substance use, and conduct disorder.
Which was primary how they.
No, sir, they have taken that. Sir, they have taken comorbidities before present, and but after that they found that higher portion were present in patients who were treated with methylphenidate. So, sir, maybe it was
ultimately higher was present. Yeah, they had to
ultimately higher was
endpoint.
Yes, sir, endpoint. So in the result, they have mentioned that higher portion of comorbidities was found.
Higher proportion of comorbidities is a different issue. Whether the group had higher proportion overall, or with time longitudinally they developed.
So longitudinally they developed.
That makes sense because the illness severity is
maybe
more, comorbidities are more. But whether we have not taken this severity as a covariate, this becomes a major issue. They have taken all sorts of covariates.
So they have not taken this as a
covariate. Very important covariate. Any comments? Questions? I mentioned they are comparing but in children, between 0 to 14 years, there is no mortality in the middle. Due to alcohol,
due to
alcohol, mortality increases. So what are the reasons?
Mortality increases.
The substance intake patient, so middle intake both.
Sir, I mentioned that a patient who has received methylphenidate, maybe who is seeking treatment, may be less prone for substance use disorder, or maybe less prone for any accident-prone death. So that is why they will have a lesser mortality compared to patients who have not received methylphenidate.
Information area is
so you papers.
Every author procedure ना procedure study इसमें कुछ गड़बड़ हो रहा है ना कैसे वो स्केल अप्लाई कर रहा है एरियाज को कैसे फाइंडिंग कर रहा है
so I mentioned in my limitation I mentioned this in my limitation that they have not given. I mentioned this in my limitation. They have not given any way how did they evaluated it on just on the database. There is no specific questions or no exact diagnosis.
Questions? जल्दी बोलो, जल्दी होगा. Difficult to sit there. After the Asta, your comments or understanding?
Sir, British done. Sir, Kamal.
And the impact factor. So this is maybe why an old impact factor. Impact factor.
So 2000, it was showing online that it is going to come.
Latest Sara IGP also newer impact factors 2.9 now. Any biological explanation?
So they have just given one explanation that they are less prone for accident and less prone for substance use. Because if a ADHD patient may be more impulsive, maybe more hyperactive, but if a patient is seeking the treatment, so he will be less hyperactive, less impulsive in taking decisions. So they will be less prone for any accidents or for any substance use disorder.
That is what they could have explained. Maybe you need some other explanations also, but that is what they have explained.
Mechanism of action in ADHD, they have not mentioned it, but I have mentioned it in my introduction. That is a psychostimulant. What it does is it stops the reuptake of norepinephrine and dopamine by acting on NET and DAT specifically. So it increases norepinephrine, it blocks the transporter and increases norepinephrine.
What is the result of it? No? सारा चीज है, सही बात है. डेटा होगा तो डेटा आएगा भी सकता है. सिमुलेंट कितने तरह के होते हैं?
जो 2010 में डायग्नोस हुआ उनको 2013 में आता है. If a child was diagnosed at 2010 in the database, they were just followed for 3 years because the end point of the study is 2030. So that is also a limitation. They just followed it for 3 years. हाँ, insurance claim लेते हैं for that medications every year. And death का भी set.
Postgraduate, no senior inside. Work on that. आप कितने बजे आई थी? आप कौन थे? आपसे बहुत सारे चीजें और आपसे बहुत सारे ये लोग और आप अपना प्रैक्टिस नहीं है, अमीज नहीं है तो आप लोग करते हैं. अनफॉर्चुनेटली आप say anything, just see the methodology. And we send our comments whether we will consider this article further or not, or we will immediately reject the article. So methodology is सबसे important. Very actually very simple. क्या proper diagnostic criteria दिया, question is क्या CVD देखा, very simple basic. क्यों नहीं देखा? Selection में कोई bias तो नहीं था, कहीं choose करने में कोई bias तो नहीं था, choose करने में randomize किया नहीं किया. All those things you need to ask yourself, and then it becomes easier to understand. And जो आपके thinking में लैक्चर में आ रहे हैं वो सब limitation करने होंगे. It may not be your limitation of the many times we will not give limitations which are we know part of the study. Still it gets published. Okay. Give Inspiral. So then this is a different issue altogether, because this is the hypothesis that it put you in your brain with increasing all these levels. You know, many people are using signal noise ratios as a hypothesis. Other neurobiological explanation, they have said that oscillation is also there, but still no one knows how to. Okay, like most of the psychiatric disorders,
It is not known.
they basically don't know definitively what is the reason, but definitely it would increase the dopaminergic transmission. But how it brings improvement when those signal noise ratios varies.
There is
But
a
no
signal
one
noise.
has a estimate, because ADHD is not localized. Right? ADHD is not localized in specific part of the brain. No one knows its etiology. So it is just by serendipity they diagnosed it, that stimulants would work, and then they have started to put some hypothesis, and we are not very complete with how it works. So, but you are presented well, and you could have risked it even more and given your own criticism and rate. ये तो सब जर्नल का होगा ना, आप तक वहाँ लाल लाल करके फिर आपको डालना. ठीक, थैंक यू.
क्यों होता है सिग्नल नॉइज रेशियो सिग्नल इंक्रीज होता है ना वो ज्यादा पेशेंट से ज्यादा ज्यादा सिग्नल होंगे तो ज्यादा टेंशन बढ़ेगा. यदि नॉन ऑपरेटिव ठीक करेंगे तो आवाज ढंग से सुनेंगे, सिग्नल ढंग से आएगा तो टेंशन ठीक होगा. और डोपामिन क्या करेगा, बहुत अच्छा आवाज पूरा देना.